to introduce our program to you. Academic Radiology Education Program is a nonprofit radiology program created by small groups of motivated radiologists from the USA, Bhutan, Cambodia, Indonesia, Laos, Myanmar, Mongolia, Nepal, Vietnam, Thailand, and Iraq. And we would like to share with you the knowledge and expertise from the West to our colleagues around the globe. We broadcast radiology live webinar on the first and the third Sunday at 8 p.m. Bangkok, Vientiane, Jakarta, Hanoi time. We try to make it consistent. However, we also need to accommodate our speakers' availability, so there may be some changes for some weekends. Please follow us on Facebook, Twitter, and IG to get the news and flyers. Once our official website is completed, we will keep you informed. Our folks who registered for AREP program last year and did not get a Zoom email invitation, please contact Thailand IT team. I will post the contact email address in the chat box. Every month, we will have quiz questions for each webinar. If you answer to right questions, you have a chance to win our small prize. At the end of the session, please help us to improve our program by completing the online evaluation form. This will take about 1 minute. Members who provide us your feedback will get certification of attendance in your email. I would like for radiology training next Sunday, the same time we will have a monthly case conference in body and thoracic imaging with Dr. Wafa from Wake Forest. This is a part of AREP mentoring program. I will send out the flyer to trainees email by Monday. Please check your email. And I would like to give a big thanks to Thailand IT team for broadcasting and recording, and Indonesia team for coordinating everything. And then I think that the end of me, I will pass on the task to Dr. Buotong, who is our moderator today. Dr. Buotong, please.
Thank you, Dr. Nat. Hello, everyone. Thank you for joining us today. I am Dr. Tia Botong, neuroradiologist from Sirat Hospital, Bangkok, Thailand. It is my distinct honor and pleasure to introduce a highly esteemed expert in the field of neuroradiology, Professor Dr. Eduardo Gonzalez Toledo. Professor Gonzalez Toledo is a graduate professor at Louisiana State University Health Science Center at Shreveport, Louisiana, USA, where he has made significant contributions through both his teaching and research. His expertise in the intricate world of brain imaging has earned him recognition far and wide, and his work has immensely advanced our understanding of brain pathology. Today, he will be sharing his valuable insight in a lecture titled Imaging Approach to Brain Tumor. This talk promises to be enlightening, offering us a deeper understanding of complexity involved in the diagnosis of brain tumor. So please join me in welcome Professor Dr. Eduardo Gonzalez Toledo. Thank you.
Thank you so much. Thank you so much for having me. It's a real pleasure and an honor to be a speaker in this forum. So I will start. Okay, I have nothing to disclose. The classification of brain tumors may be histological and morphological, histological and histochemical, and molecular genetic now. The World Health Organization classification of brain neoplasm is a system used by pathologists and healthcare professionals worldwide to categorize and diagnose brain tumors. The most recent update is the World Health Organization classification of tumors of the central nervous system revised in 2021. The one with the big changes was in 2016. And now the last one is 2021. What adds this classification? First, molecular parameters and histology. The classification integrates molecular parameters and histological features. This approach reflects the understanding that molecular characteristics often provide more precise diagnostic and prognostic information. So according to the molecular type, you have to change the treatment, the drugs you are using, or the approach. Tumor types, brain tumors are classified into various types based on their cell or of origin and genetic features. Major categories include gliomas, such as astrocytomas, oligodendrogliomas, glioblastomas, meningiomas, pituitary tumors, and others. Then there is a grading system. The tumors are graded from 1 to 4, being 1 the least malignant and 4 the most. The genetic alterations include specific genetic alterations, for example, presence of absence of mutations. And finally, the pediatric tumors. The classification has a special focus on pediatric brain tumors, recognizing that these often differ biologically and clinically from adults. So we have the origin of brain tumors as we thought before. So there was a primary cell, the medulloblastoma, and then goes to a neuronal progenitor and gives the neuron, and then the neural stem cell goes to a glial, and the glial gives the oligodendroglioma, the oligodendrocyte, and the astrocyte. So you have here a Golgi stain showing the astrocytes, two types, fibrous and protoplasmic. The astrocyte is, related to the feeding of the neuron, are around the vessels, and also they appear, mainly the fibrous astrocytes, in scars. After the brain is damaged, there are astrocytes. Then the oligodendrocyte producing myelin, and finally, the scavenger cells of the brain, the microglia. Here you have the cerebral cortex with the neurons. I will use the pointer. The neurons with the nucleus and the triangular shape cytoplasm and ganglioglioma that comes from the neurons. And you see that the cells are distorted, some of them with multiple nuclei, what is called, okay. And then the oligodendrocytes, this will have like a shape of a fried egg, you see, with a nucleus and the cytoplasm, and this gives origin to the oligodendrogliomas. Now, in glial tumors, the isocitrate dehydrogenase, IDH, we always refer as IDH, a group of brain tumors characterized by mutation in the IDH gene. These mutations tend to be associated with a better prognosis compared to what is called IDH wild type, related to growth and survival of tumor cells. So you have the astrocytomas and the oligodendrogliomas vary the aggressivity according to the presence of the IDH methylated or the wild ADH without methylation. TP53 have mutations on the TP53. That is, it calls for the P53 that regulates cell division and prevent tumor formation. So sometimes the loss of TP53 is bad. Then we have the CDKN2A mutation, loss of function of the encoded proteins P16. Also, they prevent and control cell growth. The MGMT repairs the DNA and is crucial in maintaining the genome integrity. So if you have MGMT without changes, the tumor will grow. If the MGMT is methylated, then the tumor will not grow. So you see, the EGFR is overexpressed in tumors, for example, in GBMs, and third, also in GBM. So the IDH mutant astrocytomas are classified as grade 2, 3, or 4, depending on the presence or absence of homogeneous deletions. For adult type ADH, wild type diffuse astrocytic gliomas, the diagnosis of glioblastoma should be determined the basis of presence of necrosis and florid microvascular proliferation. The newly recognized provisional tumor types were introduced as diffuse glioneural tumors with oligodendroglioma-like features. So you see that this, I go fast because it's not the main topic, but this is to show you that now it is required not only the histology, first of all, our presumption of a tumor and what kind of tumor, but also they need the histology and they need staining and they need the molecular analysis. So here you have the astrocytoma and oligodendroglioma. If it is IDH wild type that is not mutated, then ends in the astrocytoma and glioblastoma. If it's IDH mutated, then ends in oligodendroglioma, astrocytoma, grade 2, 3, and 4. So it's very important, along with our analysis of the image, you see, to have an idea of what kind of mutation has. So what happens with the imaging? In astrocytoma, glioblastoma, oligodendroglioma, IDH mutant, and 1p19q co-deleted, then appears in the frontal, has cortical involvement, heterogeneous signal, calcification, and cystic change. IP19q. P, you know, is the short arm of the chromosome because they name after petit in French is small, no? And then the long arm, they put Q because it follows the P. So no meaning. So 1P, so and 19Q co-deleted, this is, you can see, I will show you how you can see the co-deletion. Then you have the astrocytoma with ADH mutant in young adult, also is frontal, glioblastoma, older adults, IDH, you know, is not mutated. So remember, IDH mutated is better than IDH wild. Okay, what do you ask when you see a tumor in MR or CT? Is intra or extraaxial? Is a glioma? Is aggressive? Can be C blue cell neoplasm. MRS sometimes helps, sometimes not. Then we see the pseudoprogression and the pre-surgical workup. You can see in this image that this is a meningioma, that is a benign tumor. And you see that how can you determine the borders of the tumor? This is the cortex. This is the cortex, the yellow. And you can see that it is fluid. This is a T2 weighted sequence. So the white is fluid. So this is the CSF around the tumor. So this tumor is pushing the brain. And this is a sign of the fold when a tumor is extraaxial. Extraaxial means outside the brain. And you see the displacement of the sulcus and the sign of the fold. The meningioma has high cellularity. So in diffusion, this is the DWI, and this is the ADC. According to the speed of the water, you can measure the speed of the water in square millimeters per second. And then you have that the normal speed is 0.7 times 10 to the minus 3 square millimeters per second. This is the normal. This should be increased. This should be decreased, excuse me, because of the cells. The cells prevent the water to move freely along the spaces in the mass. So you see what is called restricted diffusion. Restricted diffusion, that is wide in DWI. Then if you take the DWI and you take the logarithm of the signal, it gives you the ADC. This is the ADC, so highly cellular. And you see here the meningioma is characteristic for these whorls, for these spirals. This is typical for the meningiomas. Here you have, and again, a meningioma, the fold sign, you see the tumor really enhances with contrast. You see that this after gadolinium enhances with contrast. When there is damage to the cortex, you will find edema. So when the tumor, because of the pressure, makes the lesion in the cortex, so you will find edema. So you have the DWI and the ADC. The ADC, restricted diffusion. So high cellularity with edema means the cortex is involved. And here you see again the spirals and whorls that typical from meningioma. We have in this case a 49-year-old female with history of breast recently diagnosed and discharged, who presented with complaint of 2 days headaches, nausea, and confusion. The nice episode of similar symptoms, no prior history. Okay, then you see a tumor in the temporal lobe. It's very bright in flare sequence. Flare sequence, when there are a lot of astrocytes, you will see bright. So this glia, no, the astrocyte oligodendrocyte. So you see this big tumor in T2 is bright, in T1 is dark. It takes the pole of the temporal lobe, and you see that again, in this case, you have that the cellularity is not so high because in DWI is black and in ADC is white, so no big cellularity. And here you have the typical fried eggs, and this is the example of the fish staining. You have the cells after the biopsy, no? And you see a green dot and a red dot inside the cell. This means that there is no loss of heterogeneity. You see? You see the both dots. Here we have again a tumor T2 in flare, very bright, T1. Again, the diffusion, no restriction. And in spectroscopy, shortly explained, we have a peak. These peaks means metabolites. And this peak is NAA, this peak is creatine, this peak is choline, and this peak is minoxidil. And this is lactate and lipids. So abnormal findings, this peak should not be here, is lactate because of anaerobic metabolism and lipids because there is involvement of the myelin. Then you have NAA is a representative of neurons. So this peak should be high and is small. In this case, you see that the normal is 170 and in here is decreased. The choline, because this is a ratio, the choline is a metabolite that is practically constant. So we divide the area of the curve. This is NAA. You divide by creatine and give you this number. Then you divide choline to creatine and give you this number. In this case, it's 147. You see that the normal is 0.7. Why? Because there is a rupture of the cellular membrane. This marks the cellular membrane. And minoxidil represents the glia. So when there is a lot of glia, it's increased. You see that the normal is 0.5, and in this case, we have 147. So oligodendroglioma. And here you have the fried eggs. And then you have a co-deletion. So you see only one dot in many cells, one dot. And a co-deletion of 1p and 19q. This is a small tumor in the temporal lobe. Here you have the diffusion, very small. And you see the typical elongated cells and this kind of parenchyma that does look like hair. That's why it's called pilocytic astrocytoma. Then you have this infiltrated in flare sequence. You see it also in T2, T1, in diffusion. Again, you don't have restrictions, so it's not a big cellular tumor. And then we have here the infiltrated astrocytoma with the astrocyte with large nucleus, a small cytoplasm, and you see in some cases there are abnormal nuclei. In this case, there is no co-deletion, again, 1p, 19q. In this case, I show this because sometimes you can see that you can predict that the IDH is not mutated and there is no co-deletion of 1p and 19q with the image because in flare will be bright and in T2 will be darker. So this, you can say there is a mismatch T2 flare and represents a tumor with a wild IDH and no co-deletion of 1p 19q. This is the case, and you have again the MRS, where you see the lipid, should not be here. This double peak is the lactate, anaerobic metabolism. This small peak is the NAA. It's so small that it's not detected. And then you have a high calling 243. Remember that the normal value is 0.7. And my inositol 0.78 is also increased because should be 0.5. In this case, you see a tumor with edema in the periphery. You also have this sequence that is gradient echo or susceptibility image, where black is or calcium or blood. In this case, are small hemorrhages, necrosis. So all these signs are indicating that it's an aggressive tumor. So large edema, necrosis, hemorrhage, and here you have the GBM. This is called pseudopalisade because of the necrosis of the tumor. And here you see and how they surround a vessel. Again, look at this susceptibility image with a lot of hemorrhages. You can see in this tumor an area of restriction and areas of restriction. You see areas of restriction and areas of necrosis. The white here is necrosis, the black is restriction. And this is the GBM. In this case, we had an oligodendroglioma that converted to GBM because the change in the IDH pathway. So we have an oligodendroglioma that converted into GBM. Look at the hemorrhages, look at the necrosis, check these areas, more black, that means more cellularity. This is a reconstruction of the surface, and you see the loss of the gyri. No, they are the surface. You see how it loses the gyri and the sulci. In this case, we did resting stage fMRI. This is a method that uses the ball, that is, the oxygen flows to the brain, and this can be detected by the MR. And so when there is a flow to some region, you see a signal. In this case, in resting state, you can choose the network that you want to explore. So we have the tumor here, and we explore the anterior cingulate cortex. And you see that there is no big involvement of the cortex in that area. What is this blue? Because when we compare the patient with normal patients, we see that here there is a decreased activity, decreased connectivity, and it's all around the tumor. There is a decreased connectivity of this area, that is the motor area. That's why the patient has hemiparesis and loss of sensibility. You see, so the sensory is lost on the right side. This is the left, this is the right. This is the tumor, and you see the blue areas where there is decreased connectivity. In this case, we check also the motor area. This is the motor, this is the motor cortex, and you see that the the cortex has no relationship with the tumor. Okay, amplification of the EGFR and activating mutation produce the GBM. But we go, and look, this is a cell in mitosis, or other with mitosis. This is a sign of malignancy, the presence of cells that are splitting here, you see, and there are monstrosities, these big cells here, what is called polymorphism. These are the stainings. This is the glial fibrillary acid protein. You see the increase in the fibers. In here you see the normal neurons with a synaptophysin staining to differentiate these areas from the areas involved by the tumor. And the Ki67 is an index of division, of cellular division. The higher the Ki67, the higher the aggressivity, the malignancy. Sometimes you have to differentiate between GBM and metastasis. In this case, when there is a big edema surrounding the lesion that is not proportionate to the size of the mass, you see the mass is small, you have a big edema. That is why when there were no imaging methods, they gave dexamethasone, and the patient improved because there was elimination of the edema, and it was like a proof that we were dealing with a metastasis. So big edema may be metastasis, and you have this enhancing. Look at the edema that involves all the fibers on the left side of the brain with this small metastasis. This is tractography. These are the frontal projection, the corpus callosum. The fibers going anterior to posterior are green. The fibers going right to left are red, and the fibers going superior to inferior are blue. So the internal capsule is blue. This is the inferior longitudinal fasciculus, frontal projection of the corpus callosum, green, red, the corpus callosum. And you have that this was a metastatic adenocarcinoma. Again, we have, in this case, this spectroscopy, where you can see that you don't see the NAA because there is no NAA, because it's a adenocarcinoma. You see the cells of an adenocarcinoma that form like glands. This is the adenocarcinoma. You have the lipids, lactate. Oh, excuse me. This is the creatine. Look at the peak of creatine. Huge peak of creatine. And also in susceptibility, hemorrhage. Remember, bleeding metastasis. The mnemonics is MR, CT, BB. Melanoma, renal cell carcinoma, choriocarcinoma, thyroid carcinoma and teratoma, bronchogenic carcinoma, and breast carcinoma. These are the most common bleeding metastases. Remember MR, CT, BB. In this case, we have this region of interest, but we have, look, there is neuron 132. This is the NAA. This is lipids and lactate. This is the choline. And you see in the diffusion, this area of cellularity, increased cellularity. So this goes for a glioblastoma. When you have, when you measure the volume of the fibers and also what is called the fractional anisotropy, you see the fractional anisotropy in the mean diffusivity, the metastases have low fractional anisotropy, less than the GBM. And then when the diffusivity, that is increased diffusivity, you can see that is larger in metastasis and smaller in so here you have, for example, in metastasis, you have the fractional anisotropy. This is the abnormal, this is the normal. Decrease in fractional anisotropy, increase in mean diffusivity. In the GBM, you have decreased fractional anisotropy, but not so much as in the metastasis. You see, again, increase mean diffusivity. So aggressivity, we already said that in susceptibility image, you can see hemorrhage inside the tumor. Restricted diffusion, this is the deep eye, bright, this is dark, so this is high cellularity, so restricted diffusion. Enhancement after contrast, again, you have here the tumor with enhancement after, and also increased perfusion. So you see this tumor in the cerebellum, this area has increased perfusion. And this is a way to differentiate when you have a real progression, that a pseudo progression. In the real progression, you have to have increased perfusion. Necrosis, again, in this case, you have a big peak of lipids and lactate, that means necrosis. You have NAA 176 is the normal, 0.96 here. The choline 227, very high, very high. And minocytol 0.69 also increased. Then you have disruption of the fiber tracts. You have here the anterior peduncle of the thalamus going to the frontal lobe, and here you see the loss of fiber tracts. There are these tumors that they are called blue cells neoplasm that all have restricted diffusion. And one is lymphoma. When you see a tumor with restricted diffusion, you have to think in lymphoma, mainly if it is periventricular. Then the medulloblastoma. The medulloblastoma, look in the, when you have a child with a tumor in the posterior fossa with restricted diffusion, you have to think in medulloblastoma. If not, maybe, excuse me, astrocytoma, but if you have restricted diffusion, should be a medulloblastoma. This is a 5-year-old female, medulloblastoma, restricted diffusion. You see restricted diffusion. And then in the tumor and adjacent tissue, you have abnormality. This happens also in glioblastomas. When you measure the area of edema or supposed edema, in the GBMs, you will have abnormal features. Like in this case, you have abnormal features. and this is the medulloblastoma. I go. Sometimes the spectroscopy can give a big peak of calling, like in this case. You can have restricted lipids and lactate, and in this case was a sarcoidosis. And this is the most complex of my. You have, this is a normal, and here you have lactate, and you have NAA and a choline increase, because when there is a rupture or when you have reconstruction of myelin, for example, in childhood, you will have a high choline. And so you see the choline is 321, very high. So maybe a tumor, but the presence of a big lactate with a small lipid means that it's not a tumor, but is MS. This is a tumefactive MS. Sometimes the MS have these large lesions. Follow up, there will be a change in the biological behavior of the tumors, so you will see the signs of aggressiveness. For example, you see the enhanced perfusion, the DWI restricted, and flare positive, and enhancement. And then you have the big peak of lipid and lactate, a small NAA, big choline. In pre-surgical, this is what is desirable. We say that you study the imaging, and you can tell the surgeon this is a tumor that is located in this location. Then it looks like aggressive and is involving eloquent areas or not. And so in here, you can tell the surgeon that this is an aggressive tumor. You can reconstruct the tumor, and if the motor tract is involved, in this case it's pushed, you can, here is the lesion, here are the motor, the tracts and the tumor. Then we can check the Broca location. This is a resting state. The resting state takes 8 minutes only. The patient should be still during 8 minutes. You acquire the sequence, and you can see the area what you want, the motor area, in this case, the Broca's area. This is done with a typical, the standard task, that is, the patient should do some task to have the lesion, to have the center enhancing. So, but the thing is, this takes hours, maybe sometimes 2 hours to do this, the different paradigms. But in resting state, it's only 8 minutes. You can see the tumor here, and here the Broca location, and here the motor area, and the relationship with the lesion. And it was a glioblastoma, and the astrocytoma. This patient was right-handed. So we had an astrocytoma in the temporal lobe. And you see the abnormality in the fibers. As I told you, green is anterior to posterior, blue is superior to inferior, red is right to left. This is the fiber tracking, the loss and pushing of fibers. And here you see that the patient has a big arcuate fasciculus for the language on the left. So here we suspect that the patient is right-handed but the center for the language is on the left, even is right-handed. So first suspicion, the arcuate fasciculus big on the left side. You don't see it on the right. This is the cortical thinner. You can see the tumor there. And the resting state, you see this is the tumor, the motor. Excuse me. And the broadcast area, you see that is in the left, on the left. So this patient, the tumor was resected and nothing happened because wasn't there. So as a conclusion, so standard CT NMR can give us the tumor location and involvement of non-eloquent areas of the brain. Addition of DWI, DTI, SWI, PWI, MRS can provide additional information about aggressivity, sometimes tumor type, progression, or pseudo-progression. Resting state and DTI identify regions that must be avoided by the neurosurgeon. Pathology will characterize the molecular characteristics of the neoplasm. And I thank you for your attention. If you have some question, I'll be glad to answer. And again, thank you for having me here, and I hope this will be useful to you. Thank you.
Okay, thank you, Professor Gonzalez Toledo. Next, we will move to the Q&A session. And anyone who have any question can type it in Q&A or chat box. And first, I have one question.
Okay.
Okay. If it when we report the tumor, can we just report it in as a low or high grade tumor?
Excuse me, can you, yeah.
I mean,
What is the question?
if we don't have any advanced MRI, can we just report the tumor in the high or low grade tumor, just without specific type?
Yeah, you can locate the tumor very well with the computer tomography, of course. The thing is you have two possibilities, the CT without and the CT with. And so these are the possibilities with CT. The hemorrhage will be difficult to see with CT, you see, but you can see the edema, for example. The larger the edema, you can see necrosis with CT. The enhancement also, the heterogeneous enhancement will be a sign of aggressivity. And also the infiltrate to the adjacent structure, for example. So CT, yes, you can also do. When the CT started, we thought that measuring the T2 value would be useful, but there is a lot of superimposition of values between benign and malignant tumors. Many times I calculate the T2. You can do this by having a T2, what is called a dual sequence. You have a proton density and T2 in the same sequence. So you have one image of proton density and one image of T2. you place a region of interest. And then there is a formula that gives you the T2 in milliseconds. The normal value is 70 milliseconds. So in tumors, this changes. This can help you. If you are interested, I can, everyone who wants to do this method, just send me an email and I will send you the explanation how to do it. My email is E like Echo, C like Charlie, G like Golf, T like Tango, O like Oscar, L like Lima, E like Echo, D like Delta, O like Oscar, ECG Toledo @gmail.com. Feel free to ask me, and I will give you this the formula and how to do it. Any question that now you will have thinking about the presentation, please ask me. I will be glad to help. Same with the methods, how you do a spectroscopy, how you do a resting state. Spectroscopy also with now with artificial intelligence, you know, there is they examine all the metabolites and give you a prediction. For example, if it is an astrocytoma or oligodendroglioma. Now they are not yet for everybody. You have to have a lot of knowledge about how to do artificial intelligence and all that. I think in the near future, we can have tools that we can use in artificial intelligence, because now the experts are developing the sequence, you know, the language generally, for example, with Python, this language that you can use for artificial intelligence, but it's very complicated. You have to have a lot of cases. You know that, for example, to recognize a face, they had to use millions of faces. In some cases will be more difficult. For example, how many GBMs you see, or for example, how many cases of degenerative disease, you know. So this is one of the problems with artificial intelligence. In some, I read that they say, oh, medicine will end because artificial intelligence will do the diagnosis. The problem is, like in this case of tumors, imagine that you want to know now if they are IDH mutated or not. I don't know in the future if we discover some other metabolites or genes, and the machine, this is not knowing. You have to feed the machine. So always the physician will feed the machine and will train the machine. So the physician is not that, you know, will be replaced by the artificial intelligence.
Okay. And we have like anyone want to ask a question? I think.
Hi. I am from Myanmar, and I'm sorry if some questions are stupid. I would like to know that in our country we have a little bit some limitations. Although we have MRI, we still there are so many areas that do not have MRI, and we cannot apply some fancy techniques like functional MRI or fiber tracking or MR spectrography or MR spectroscopy. So in such cases, in such areas, how can we decide about the pseudoprogression, and if there is pseudoprogression and like some cases quite challenging, like for example, like infiltrative astrocytoma, and sometimes the imaging features are quite very difficult to decide and to give the definitive diagnosis. So in such cases, if there is any suggestion or advice to do the diagnosis with the CT alone or basic MRI sequences? Thank you.
Yeah, CT, as I told you, I really focus in the most advanced method, but this is not, even it's not available in everywhere. The second thing, they are time consuming. So even in the States, for example, they don't use these sequences. They use T1, T2, diffusion, and susceptibility, and they don't use the other sequences. But if you have a CT, maybe you have also nuclear medicine. I don't know if you have nuclear medicine. Nuclear medicine, you can label the tumors, and this will be of great help. The other thing is progression and pseudoprogression is not so easy, even with MR. Even with MR, really it's difficult sometimes to decide if it is a progression, pseudoprogression. So you have to check the clinical features. This is a thing that is very important. You cannot trust the imaging alone. You see, you have to see the clinical feature of the patient. If the patient is doing well, is the function is preserved or improving. So then you decide about that. And you can tell the surgeon, this is growing, this is not growing. Maybe this probably it will be a necrotic area, but we are not sure. So the neurosurgeon will decide according to the clinical picture. You see, sometimes the patient has the image is worse than the condition, the patient condition. So you decide according to the patient condition. I think this, and also if you have nuclear medicine, you can also check the uptake, you see, fluorodeoxyglucose, or if you have some other kind of radioisotope, it can help.
Thank you so much, sir. Thank you.
You're very welcome.
Okay.
Nat is willing to speak.
Or we have another attendee raised the hand, Mr. Shantalangsi.
Okay.
Okay. And would you like to have some question? Or maybe Dr. Nat? Okay. I think it's time to move to the our next session, and thank you all to participate in the Q&A session. This year we have the new quiz challenge for the all attendees. Okay, I will have to share my screen. Okay. Okay, we have reached the interactive segment of our session, which from the knowledge we have been given by Dr. Gonzalez. Okay, the person who answered the right answer of this quiz challenge in this month, both the lecture and the next lecture, we will provide you the gift, which is a lovely bracelet here, and we will email you the lucky participants. Okay, the quiz that I give you here is a case of 5-year-old Thai boy presented with vomiting and left facial palsy. As we can see here, there is a mass in the posterior fossa. It's a little bit beyond the scope of this lecture, but I think you kind of can do it. Okay, and my question is, which genetic alteration is considered a characteristic marker for the tumor? A, IDH mutation, B, 1p19q co-deletion, or C, H3K27M mutation, or D, SMA SMARCB1 gene. So you guys can answer this quiz by scanning the QR code. I will give you another 1 minute, okay, to answer the question. Okay, the last 15 seconds. Okay, time's up. I will give you the answer. Okay, this patient was underwent the surgery and give the pathological diagnosis of diffuse midline glioma or H3 diffuse midline glioma with the new name of H3K27 alter, which is defined of the IDH right high glioma that's located in the midline location, which is characteristic of the expansile mass at the brainstem, and it had the exotic component that go around and got the basilar artery for 1 year, and also it tend to CP angle on the right side. Okay, so as you can see from the choice, the correct answer is that H3K27M mutation. Okay, I hope you guys give the correct answer.
This is not happening. Just to let you know why Professor Toledo, he showed you the Tigers. So it's like a football team of LSU Tiger, and like the Baltimore the Ravens. So every city have their own football team and they have their own motto. It has nothing to do with not like a lot of Tigers in Louisiana, but that is a football team.
Okay, and as we draw this session to a close, I would like to thank you all for active engagement. And today we cover a wide range of topics from the basics of MRI and CT to the advanced techniques that we are that help us to diagnose and manage the brain tumor. And before we go, I would like to encourage you to do the evaluation form. And after we complete the form, we will provide you the certification, and you can scan the QR code here. And I would like to invite you all to join the next lecture event at 28th January this month. We will have the privilege to welcoming Dr. Bandit, our renowned expert in the field of head and neck radiology from University of Texas Health San Antonio, Texas in USA. And he will lead us to the complexity of imaging approach to gastric and supragastric cancer. And with our lovely moderator, Dr. Uttaras from Sivarat Hospital. Okay. And I hope you all, thank you very much, everyone. Thank you very much, Dr. Eduardo Gonzalez Toledo. And I hope you all have a happy new year and have a best year in 2020. Thank you very much.
Thank you. Thank you very much.